Welcome, everyone, to today's virtual policy forum, From Crisis to Care, Integrating Healthcare and Public Crisis Response Systems. We're so glad you could join us for this timely conversation. As people begin to join, I'd like to start with an interactive poll. Please take a moment to pull out your phones and participate in our opening question. Please register by texting Health Policy 261, no spaces, to 22333 or by visiting pollev.com/healthpolicy261. Our question today gives us a sense of who is in the audience. The first question is, what role or roles do you play in supporting mental health? For example, a policymaker, a staffer, an advocate, a researcher, a crisis counselor, etc. This might be in a professional, personal, or volunteer capacity. We'll just give it a minute and start to see some responses come in. Be a policy staffer. If there's, yeah. Okay, sorry. Okay, now I can start. I start seeing a clinician, a project manager at a local doctor's office, I assume, overseeing the adult and youth crisis centers in my region. Researcher. If you've just joined, we're just opening with a poll that kind of provides a sense of who is in the room. A project coordinator for a crisis continuum, great. Director of Quality Management. A lot of different folks are joining. Project coordinator for SAMHSA, grant analyst. Wonderful. Okay, so it looks like we have a great diverse audience joining today, so I'd like to move us into today's program. I'm Renee Gross, Senior Health Policy Consultant with Kaiser Permanente's Institute for Health Policy, and I lead the Institute's mental health work and also volunteer as a crisis counselor. I'm filling in today for our Executive Director, Ceci Oregon, who is feeling a bit under the weather. At the Institute, we host events and publish information to shape policy and practice on important health topics. We convene experts to share knowledge, spark discourse, advance collective thinking, and explore opportunities to cultivate healthy communities and promote more accessible, high-quality care. This month marks the one-year anniversary of the launch of 988, a three-digit number for our National Suicide Prevention and Mental Health Crisis Hotline. The creation of this number drew attention to the growing mental health crisis in our country, and I'm pleased to kick off today's conversation with leaders who are working to develop a fuller continuum of care for crisis services. First, I'd like to share a little bit of housekeeping. After our keynote, and again after our panel discussion, we'll take questions from the audience. And you can submit questions through the Ask a Question box on your screen at any point during the forum. If you're on a large screen, it'll be to the right of the main window. On a smaller screen, it'll be right below. We likely won't have time to get to every question, but we'll do our best to answer as many as possible. And if at any point you experience technical difficulties, please submit a question to the host through the Ask a Question box. This event is being recorded and the video will be made available on the Institute for Health Policy's website within the next couple of weeks. On to our content for today. In this conversation, we'll be discussing ways that policy and practice can better integrate the public crisis response system with healthcare systems. These policies have important implications for how existing crisis support systems function, how providers care for patients, and how payers support quality and continuity of care. And now I'd like to introduce our keynote speaker, David Covington, CEO and President of RI International. David is a licensed professional counselor, behavioral health innovator, entrepreneur, and storyteller. David hosts and curates the popular weekly 988 Crisis Jam learning community in partnership with SAMHSA and the National Association of State Mental Health Program Directors. David holds a number of leadership positions, including as a member of the U.S. Department of Health and Human Services Interdepartmental Serious Mental Illness Coordinating Committee and on the National Action Alliance for Suicide Prevention Executive Committee. David previously served as Vice President at Magellan Health and was responsible for executive and clinical operations of the $750 million Arizona contract. He was also past president of the National Suicide Prevention Lifeline Steering Committee and past president of the American Association of Suicidology. We are truly honored to have such a champion of this work with us today. Now I'll turn it over to David.
Thank you so much, Renee, and thank you all for being a part of this event. And imagine for a moment that it was a day like any other, but in this case, the Chilean miners who let me just share my screen. These Chilean miners began the day like any other, but because of an explosion and a collapse, found themselves in utter darkness in a room not much larger than this area that I'm standing in right now. It took a couple of weeks before we were able to reach them to even ascertain if they could be rescued. We drilled a hole about 4 inches in diameter to make contact, to connect with them, and to find out that they were alive. And then over the course of weeks, we began to drill a larger opening that would allow us to send someone to them and ultimately to bring them out one by one, all 30. After weeks, we supported them through that connection. We went to them and we rescued them and brought every one of them to us. The 11th person who came out said, "Thank you for believing that we were alive." Now, there was no stigma and no shame. It was a global response and around the clock. Well, ultimately, with an approach of someone to connect with them, someone to go to them, and ultimately a safe place for them to be, that they could get help. They had to come out. Now, that rescue, you might say, well, that occurred on a one-off. That's not something that happens hundreds of times an hour throughout the country, around the clock for the whole year. And yet this idea of someone to call, someone to come, and a safe place to be, to get help, to go, is exactly what our country has invested in and deployed if your worst day is a medical emergency. We do this continuously through 911, through ambulances that are rapidly on the scene, and through emergency departments where you can get care. But the point here is that it wasn't always that way. This is the Atlanta phone book from 1966. And for those of you who don't know what a phone book is, Google it later. It's a long story. But we used to get these books that would tell us who to call. And this is the very front inside page. It has a large exclamation point and says emergency numbers at the top. But then you'll notice it actually doesn't list the emergency numbers. You have to do your homework to figure out what your numbers were. And then I guess you were supposed to rip this page out, write those numbers on it, tape it to your refrigerator, and then have your emergency in the kitchen. 911 in 1968 changed all of that and simplified our outreach to get care. But 911 did not change the plight of so many people in a medical emergency because 911 did not possess the capability to go to individuals and get them the help they needed. For many decades, we used coroners' vans and station wagons. We used hearses. We would grab anyone, anytime, a family member, a friend, a bystander, to try to get someone to a hospital. The first 911 calls are answered in 1968. If you cascade forward 12 years to 1980, John Lennon is shot in the back 5 times right off of Central Park in the largest city in the United States. And he is transported to the hospital in the back of a police car. It took us time to build out the resources required to be able to respond. But even the hospital emergency department didn't look like the ones of today. At that time, the door was locked. You had to knock, ring a bell. If someone was available, they would come to you and crack the door open. They didn't just let you in. They wanted to know if your physician was on panel with the hospital. It was a different world with a different approach, and not everyone got care, certainly not in their own time and space. And we as a country decided that had to change. This is the report that came out in 1966 that laid out the blueprint of coordination and communication that would be 911, of the ambulance response that would be rapidly on the scene to provide care where you needed it, and for those who needed more, emergency department capacity that was immediately available and accessible to all. It made the argument that you were safer on the front lines of Vietnam to have an accident where they had medics in the field, rapid helicopter transport, trauma units with surgeons standing by, than you were on the streets of metropolitan America. And over the course of time, we shifted all that and developed the amazing system that we have today. Now it is time. The promise of 988, if you will, is a system of care, a dedicated behavioral health response for those with a mental health, substance use, or suicidal crisis. I did this particular graph before 988 launched. At that time, 2.5 to 3 million calls were going through to the Lifeline. SAMHSA reports over 5 million contacts through call, text, and chat on 988 this past year. So 988 is already beginning to make an impact. But there are another 13 to 15 million people calling through in local, county, and state crisis lines. And we don't know for sure, but we estimate between 25 and 30 million people are calling 911 directly. So we now have the opportunity with 988, just like we did with 911, to begin to coordinate a response that is different from what happens to so many today. For many individuals with more significant needs, they find law enforcement driving up into their driveway with lights flashing, their neighbors see it. And even though most are not arrested, many are handcuffed in the back of the vehicle. And during that time of needing support and care, are finding a very traumatic episode. But most, even if they're not involved with law enforcement, if they're going to get more significant care, they're going to go through this choke point, this gauntlet of medical clearance in a hospital emergency department, where they're likely to spend days. The Seattle Times in 2014 found an average of 3 days, and it found that people were frequently handcuffed to a gurney in a hallway because of a lack of space and attendants who could support those individuals. They're going without care, they're going without treatment, and the entire circumstances are not perceived as care, more likely to be perceived as punishment in that time. Kana Inamoto was acting director at SAMHSA, and in early 2020, her daughter Raina, in a suicidal crisis, meant that they went into an emergency department and they were there for 3 days. She had been the top administrator in the United States and faced the same kind of situation. And we still have this approach that our detox centers, our inpatient, our crisis stabilization residential, these facilities they're the ones with that bell that you have to ring and the door is locked. Going through the hospital ED, to be able to be considered for care, as opposed to the type of ready response that we have in the medical system. So imagine a system. The promise of 988 is everyone in crisis gets care that feels like care when and where they need it. In order to accomplish that, we talked about that paper that laid out the blueprint for the medical emergency system. We now have a blueprint for the behavioral health emergency system. SAMHSA's national guidelines, best practice toolkit for behavioral health crisis care was published in 2020 and laid out this same someone to call, text, or chat, someone to come, and a safe place to go. Now, 988 is off and running, and we have 220 crisis hubs across the country that are facilitating through technology and caring engagement over the phone. And that's going to be a solution for the vast majority of individuals. But for those who need more care, the technology to dispatch mobile teams to the person, not sending out law enforcement or ambulance staff, when what is needed is to sit down and begin to inventory the strengths of that individual, assess what's going on, work to de-escalate that crisis in the moment, and put together a plan that helps that person get back to their recovery journey by integrated into their life. And here's a mobile crisis team going into that kitchen. Here's a mobile crisis team meeting that individual on the street. And this becomes a very significant alternative to the current system where law enforcement is not only engaged, but has that burden of not knowing what to do. The volume of this, Phoenix has been doing this approach for well over a decade now. And this is the heat map that I received from Solari, which is the statewide 988 crisis hub, that they dispatched 28,000 mobile crisis team contacts just in a one-year time frame across the county, which means law enforcement is not engaged and you get this more compassionate, caring contact. But for those who needed more, directly accessible facilities. This is the RI facility in the West Valley of Phoenix, more welcoming environments that are actively supported by peer staff alongside clinical nursing and medical resources. And these are some of our facilities across the country. But this is, again, the map of Maricopa County in Phoenix, Arizona, where 3 different organizations operate the 3 different locations that are geographically placed so that law enforcement is incentivized. They don't need to go and wait in this gauntlet of hours in an emergency department where they themselves, they call it wall time, where they're standing around waiting because they're caught. The alternative for law enforcement is to go book someone into jail because they know they can be in and out in 45 minutes. We've made it even faster than that, that the most easy thing that a police officer can do if they get a call or they engage someone who has a mental health or substance use or suicidal crisis, that one of these facilities is within a 15 to 20 minute drive for 85 to 90% of the county's entire population. And when they go, the SAMHSA guidelines outline a crisis receiving facility. Actually, that was envisioned first by the pioneers of CIT, Randy DuPont and Major Sam Cochran. They talked about law enforcement needed someone they could go and just drop the person off. So in Phoenix, when they go to one of these facilities, they don't call ahead. They don't go on a web portal. They don't do anything other than just drive to the closest available facility. There's actually 2 dedicated police officer parking spots to the right of this picture, but they don't park there. They just park right on the curb there, which is great. They get out of the car and go directly to a specific police entrance. Now, this entrance is not a fancy entrance for police into admissions. It is actually a connection to, think about an airlock that connects directly to the unit, to the 23-hour temporary observation unit, where they go with the individual, the guest who's in crisis and needs support. They go to that door, knock on the door, ring the bell. Someone immediately comes, and this is the room immediately inside that door. The door on the left connects directly to the unit. The door on the right goes to the outside. And in this small room, there's a connection made, introductions if necessary. If they have paperwork, it's shared. And the individual with a peer and a nurse practitioner is then begin to be introduced into getting some immediate support. They didn't go to a hospital first. If there's a need for medical clearance for those very few who have something that requires additional medical concern, then in the Arizona system, that's on the shoulders of the behavioral health system. 19 out of 20 individuals don't need more intensive medical care. And for someone who does, having that need stabilized and then returning to the unit is the expectation, so that law enforcement in 5 to 10 minutes is back on the street, back doing public safety. So we've incentivized the system where that care is available and we don't get into all of this punishment that is so routine in systems today. And then that environment, again, is one with peers that are engaged in the process, someone who might have been in the back of a police car themselves, lived that journey, and can begin to work alongside with nurses, clinicians, and others to get where they want to go. So the promise of 988 is a system, again, akin to what we already have on the medical emergency side, but a behavioral health response to a behavioral health emergency that is dominated both at the mobile level, the 988 level, and at the crisis receiving level by people with lived experience who've gone through training and become certified peer specialists working within an interdisciplinary team. Now, Dr. Richard McKeon, I believe, is going to be part of this event. Richard and I started with others a learning community that meets every Wednesday at 12 noon Eastern time called the Crisis Jam. And you can go to talk.crisisnow.com. But Richard's called this the most significant opportunity to transform mental health in the nation's history. And with that vision that SAMHSA has of someone to call, text, or chat, someone to come, and a safe place to go, we're going to create an entirely different set of alternatives and options and care that is not only going to save lives, but provide care and avoid pain and suffering for so many lives. Thank you.
Thank you so much, David. We really appreciate that wonderful presentation. And now I would like to take a few questions from the audience before we move into our panel discussion. And the first question I've received is, given the rollout of 988 over the last year, what are you most hopeful about, and what do you think we need to be paying more attention to?
Yeah, so for me, the engagement of law enforcement is the most significant component. And there are two things that drive that: the choke point of the hospital emergency department and the way that we do this so frequently, and the lack of mobile crisis services as an alternative. But the burden on law enforcement is hard to imagine. The number of cases when San Diego County launched its mobile crisis initiative a couple of years ago, the police chief at the press conference announced that her team of law enforcement officers had been involved with 45,000 interactions for individuals with mental health, substance use, and suicidal crisis the prior year. And she believed that the vast majority of those could better be handled by a team of a social worker, a counselor, and a peer. The burden that we put on law enforcement when they're trying to do public safety is immense. And on top of that, we have terrible outcomes continuously with a public safety response to a person in a mental health crisis or a substance use or suicidal crisis. So the focus that we're seeing, California and Kentucky just got their state plan amendments approved through CMS to use ARPA funding to drive mobile crisis forward. We're just seeing communities throughout the country, and SAMHSA's leadership, they are now going to I think they're calling them the town halls on the front lines, where they're marking that 988 celebration and going out to places that are innovating in this space. But we're seeing a lot of engagement and investment, and most every state is beginning to think through a blueprint for how they advance that to that next step.
Great. It will be really interesting to see what states come up with. Another question we have is, what signs tell you that the 988 system is starting to make a difference?
Well, look, Richard has been the branch chief of suicide prevention and led the SAMHSA steering committee around the Lifeline, which is the foundation on which 988 rests for, gosh, Richard, going back to the early 2000s. And when the Lifeline itself was established in 2004 and 2005. We had such a patchwork of reliance on local, county, and state funding that this was all just really challenging until 988. But one of the most significant breakthroughs for me is in today's Crisis Jam, we showed the SAMHSA performance management website, which has the exact volume by component parts of the 988, what went through the Veterans Crisis Line, what came through on call, text, and chat, and the performance on that in terms of abandonment rate, on average speed of answer, the service expectations. So we've had a mammoth leap forward in performance, and the visibility, transparency, and accountability for all that, to me, is a gargantuan breakthrough and shows the level of leadership, investment, the funding and support behind this, the collective impact, and it just lays a foundation for success going forward. Richard's shaking his head, so that's good.
Yeah, he's in agreement.
I
think there's just time for one last question for you, which is again from the audience. What is the training and education for peers that's available? So this is a state by state, and in some states area by area, that the 220 call centers, text chat centers across the country are all independent organizations that are accredited through various bodies like the American Association of Suicidology, with a basic set of expectations from SAMHSA and Vibrant. The expectations of those taking the calls, texts, and chats is that they are caring, competent, and appropriately trained. And so while a certified peer specialist would be great to do that under clinical supervision, is how the SAMHSA guidelines describe that, we have a whole variety of different approaches across the country as we see that. But if we talk about what we do see state by state, we don't have the professional orientation around peers is, trailing. If you think about social workers or counselors, the National Board of Certified Counselors is so proud that they just got Medicare credentialing for billing certain services, but that took them decades. So we don't yet have a national certification for peers. We do have some elements out of Mental Health America, but nothing that is quite a national certification. Each state's a little different. Recovery Innovations, or RI International, we are one of actually hundreds of organizations nationally. We're one of the largest in terms of, we've trained almost 20,000 certified peer specialists over the course of time, but there are many out there. And we're going to see that continue to refine and define as peers are more involved in crisis receiving facilities. They're commonly on mobile crisis teams, and they're answering text, chats, and calls. We're going to see that continue to move forward and become more tight. But right now it's very much a state by state, or even more than that, down in terms of what the expectations are for what that training is. Great, thanks. And I imagine we might dig into that a little bit more with our panel discussion. But now I'd like to move us to our panel. David is also going to join us, and we will start by having each speaker introduce themselves. Unfortunately, Monica Johnson from SAMHSA was supposed to join us today, but she had an emergency this morning. And instead, we have Dr. Richard McKeon stepping in, who is Senior Advisor in the 988 and Behavioral Health Crisis Coordinating Office at SAMHSA. And we're actually going to kick it off with Dr. McKeon to introduce himself and his role.
Thank you so much. I'm glad to be here, and regrets from Monica Johnson that she was unable to make it. That I'm a senior advisor in the 988 Behavioral Health Crisis Office. And one thing that's really significant to realize is that there is now a Behavioral Health Crisis Office. There is a home in the federal government for the very first time related to behavioral health crisis services. Now, we've had the National Suicide Prevention Lifeline since 2005, and I've been engaged with it since that time. But there was never but that was really the only initiative that really focused on crisis services. And then, as David has most eloquently described, SAMHSA has a vision in our National Behavioral Health Crisis Guidelines of a transformed crisis system in the United States. And we in our report to the FCC, required under the National Suicide Prevention Lifeline Improvement Act, when we were asked to weigh in on whether a 3-digit number was feasible, whether it was advisable. And we said, yes, it was. People are going to remember a 3-digit number in a moment of crisis when they would not remember a 10-digit number. And if you imagine a family member having severe chest pains, it's likely that the person, despite their crisis, and the family member are going to remember the number 911. Unfortunately, they would not remember in a suicidal crisis 1-800-273-8255. But the aim is that they will remember 988, and that 3-digit number can become a catalyst for behavioral health system crisis transformation in much of the same way as David described that 911 became a catalyst for transformation of the emergency medical service. So that is SAMHSA's vision. That's SAMHSA's role. And compared to the early days when Mike Hogan, former mental health commissioner, described the Lifeline system as being the only safety net system being supported by bake sales, the Biden administration has now invested almost $1 billion in building this system. So it's a tremendous opportunity for all of us and for all Americans.
Great. I think we're going to move on to Dr. Don Mordecai for some opening remarks.
Sure. Hello, everybody. Thank you for joining us. It's really an honor to be here with leaders in this space like Richard and David and Wendy. Renee, thanks to the Health Policy Forum for hosting this. I'm Don Mordecai. I am the National Leader for Mental Health and Wellness for Kaiser Permanente. We serve over 12 million members really across the United States, from regions as far flung as Hawaii to the mid-Atlantic states. And I'm just listening to Richard and David's story about 911. I just want to reflect on how exciting this opportunity really is. I'm a clinician. I still see patients at our San Jose Medical Center. And as I was listening, I was thinking about one of my patients who's an adult with autism, who sometimes got into crisis. And that crisis, as far as I'm concerned, never was a suicidal crisis, right? So the suicide prevention lifeline, although crucial for many, many people, was never appropriate for her. And then her parents were never inclined to call, even when she was in a serious crisis, and she and they were at some risk because of the fear of what would a police response look like. If the police response was okay and they took her to the hospital, what would their daughter encounter in the emergency department? And frankly, even if the emergency department piece went okay, what would she encounter in a psychiatric hospital? Would any of those settings be appropriate for her? And their answer really in their hearts was no. And that meant they were holding the situation themselves. And fortunately, nothing serious has ever happened. But you think about that repeated over and over and over. There are so many people who have crises that are mental health crises, but are not suicidal crises. And the opportunity, and Richard's been someone who really taught me about this, and David as well, is really unprecedented. That this administration right now is committing more resources to mental health than any other administration previously. We often thought of the Kennedy administration as being very pro support for mental health, which was true. But in terms of actual resources being devoted, the time is now. And that's a very exciting thing. I also look out at the field and think, oh, this is kind of daunting. There's a lot of challenges here. I assume we're going to talk about that a little bit in terms of knitting this together in the way that the 911 system has, over quite a bit of time, and I hope it doesn't take as much time, has eventually come to be knit together in the way that we see and expect in our lives today. So to get there for mental health would just be an amazing step forward for this country.
Wonderful. And now, Wendy, would you like to provide your opening remarks?
Sure. Good afternoon. I'm Wendy Martinez Farmer. I've worked in crisis services for over 25 years. I'm liking Zoom. It's kind of hiding the gray streaks. I forgot that Zoom is friendly. I had the privilege of operating the Georgia Crisis and Access Line for many years with David, and also mobile crisis in 104 counties in Georgia. I currently serve as the RVP for Crisis Services in our Crisis Center of Excellence at Carelon Behavioral Health, formerly Beacon Health Options, where we provide administrative and quality oversight to crisis programs in 7 states. And I'm very proud that over the last year, we've been able to lend our some capacity and our capabilities to help serve as a backup center for text and chat for 988. And recently, we're able to start providing text and chat services in Spanish. So as a granddaughter of 2 Spanish speakers, I'm very, very proud to have been involved in that process. I could not be more proud of what's happened over the last year as 988 has come to fruition. Many of us have been working and hoping for this, and David and Richard especially have worked very hard to bring this to fruition. I think what I'm most excited about is, one, knowing that with the increased answer rates across the country, particularly in text and chat, I think we intuitively know that that means that more young people are getting the care that they need, because if you're a parent, you know that kids are not likely to pick up the phone, and that text and chat is such an important resource for our young people who are in crisis. I'm also proud to see how crisis systems are really starting to develop. Certainly there are opportunities and challenges, but we're really starting to see communities work together to knit together the best safety nets we can for individuals who are having their very worst day. As David, really poignantly pointed out, individuals in a medical crisis we demand that they get the care that they deserve on their very worst day. And we need to make sure that that same system is in place for people who are having behavioral health emergencies. And I think this is really the first step in making that happen.
Thank you, Wendy. Okay, so I would like to start off by unpacking some of what David described in his opening remarks and examining how crisis services can fit into this ideal continuum of care. And since each of you represent different parts of the continuum, I'd like to hear where you think there are opportunities to better integrate and work together to coordinate services, and then also what are some of the challenges associated with achieving this vision. And maybe we'll start off with the healthcare perspective, Dawn, Wendy, and then move to Dr. McKeon. And David, you can have the last word on this one.
Sure. I think as this is evolving, what we at Kaiser Permanente see as big challenges, or how do you integrate this external public-facing system with our care system, right? We're fully prepared to do the hospital-based, the professionals, the psychiatrists, the social workers, the psychologists. That's our realm. The crisis realm, one of peers, public-facing. How do we bring those two together? And I think that requires a fair amount of thought. I know that is going on in many spaces too. But when somebody is seen by, they call 988, they're seen by a mobile crisis team, they're brought to a residential center, but then they need something more. Or maybe they're seen by a mobile team and the mobile team identifies that they need the hospital. How do we then link from that public system, the publicly funded systems of 988 and the crisis response, the mobile response, into what are often private healthcare systems? And so I want to make sure that those linkages are tight, so that when Kaiser Permanente members who need hospitalization, need psychiatry, can easily come into our system. I think if that's done well, it could work extremely well for our members. If it's not done well, then we have Kaiser Permanente members that might be in hospitals that we don't know that they're there. How do we repatriate them? That kind of thing. So I think making those tight connections is important. And I'll just throw out, a challenge that we see is we, at least in California, we interact with the public mental health system across 58 different counties. Wendy, you mentioned Georgia. I don't know how much different it is, but each of these counties has a somewhat unique system. And so, as I was thinking about this conversation, if the counties across California or in the Bay Area could get together and agree to sort of a standardized approach, that would be very helpful for entities like Kaiser Permanente to then plug into. So we're making sure that these handoffs are working for our members and patients.
That makes a lot of sense. I think the other thing is really working together on sharing data and ensuring that we have great visibility into the whole care journey for individuals, because like you said, there are very often services that happen outside of our knowledge or outside of our radar. And it's really important that we understand that whole care journey for individuals who are in crisis. And then how are individuals accessing crisis services? Unfortunately, very often individuals are first accessing services while they're in crisis. So how can we get a better visibility into how often that's happening and who it's happening to, so that we can make sure those individuals really understand how to access crisis services in their communities, so that they frankly don't end up in emergency departments when they don't need to. I think one thing that we're seeing that is a great opportunity here is to equip 988 centers and mobile crisis teams with access to providers that provide urgent access to care. So that, when someone calls a crisis line, you're going to use the tools that you have in your toolbox. If sending someone to the emergency room is the only option you have, that's the tool that's going to be used. So can we equip crisis call centers and mobile crisis teams with urgent access to providers? And can we incentivize providers to be willing to provide urgent access for people who need that level of care, and to really work really collaboratively together to make sure that information is shared amongst all parties so that we can serve as the best safety net possible.
So I guess I go next. And so let me echo something that Wendy just said, which is the importance of data, so that there is transparency and accountability in what's happening within our crisis systems, and the connection to needed care after the crisis episode is a hugely important piece to this. So I would emphasize really three things. They all have to do with what happens after the call, the chat, and the text to 90. We made tremendous strides in increasing our answer rates, lowering average speed to answer. I can confidently say that compared to the start of this administration, every single day, hundreds of people, likely more than 1,000, who are currently suicidal are accessing the system who were not able to get through previously. So it's been a huge step forward. But now the question becomes, what happens after the call? What happens after the chat? What happens after the text? Many things are going to get resolved on the call, the chat, and the text, but not everything. And sometimes even though if suicidality is reduced, there still needs to be that connection to care. So three critical areas. One is the connection to mobile crisis, for when there is a need for someone to come to the person quickly. And for the SAMHSA's national guidelines speak to the importance of being able to dispatch mobile crisis, or at minimum have a closely coordinated working relationship. And certainly this administration has been committed to increasing the availability of mobile crisis services, the increased federal match for mobile crisis, some of the other work done by the Center for Medicare and Medicaid Services to promote mobile crisis. Second area is the connection with 911 and the coordination with 911. There's excellent examples of crisis centers working with their 911 public safety answering points. D.D. Hirsch in Los Angeles, Behavioral Health Response in St. Louis, work also going on in Arizona and Texas and Harris County, where they co-locate in the 911 public safety answering point So there are calls that go into 911 that can be handled by mental health. In Austin, they have a press 4 option when you call 911 for mental health. And so they're able to do that right in the public safety answering point. So some calls can be diverted, but there are also times when calls are going to come into 988 and we need rapid access to 911. In particular, when there are suicide attempts in progress and there's a need to get to an ambulance to someone quickly. And then the third area was the area that Don was really speaking to, the connection to the ongoing care system. And their data transparency and accountability are important because people need to be able to get into care quickly. If you're talking to somebody on the phone and they're having suicidal thoughts, if you know that they can be seen the next day at a certified community behavioral health clinic, which is required to provide next day access, then you may be less likely to have to send more intensive means if you have that assurance and you have a working relationship to get people into care quickly. And so one of the things that I would hope ultimately is that 988 really shines a light on and helps to improve overall mental health access, the way access to the immediate crisis response via call, chat, and text has already been enhanced by 988.
So we obviously have to build out these 3 core components and a rich system of supports and capacity behind that. What Wendy and Don and Richard have been talking about. We imagine a 911 ambulance services and hospital EDs that don't have the kind of ICU, trauma care, pregnancy care, cancer care, all of the rich set of resources and supports that are in place. But as we go into that, I think a obvious starting point is what Wendy talked about around immediate access to urgent connections. We've had with NAMI and the National Association of State Mental Health Program Directors, a recommendation for states of a best practice legislation they could use to fund 988 using fees attached to cell phone bills, is similar to the way that we fund 911. 8 states have already passed that legislation, and Washington State actually included a mandate along the lines of what Wendy is talking about, that health plans must be able to provide next day urgent appointments. Again, all of that's going to roll out as it goes, but that's a great starting point. The other thing I just add on, Richard was talking about the coordination with 911s. And I do think that technology focus that Don was talking about, in LA alone, where Dee Dee Hirsch is, there are 80 plus PSAPs or 911s. And when one of them calls the other, all of the data flows through with the same kind of protections and privacy and transfer that we see in the financial area. So that kind of coordination, think health information exchange, comes to this work. Wendy and I were actually part of the team that built out the first statewide software coordinating system that had GPS-enabled mobile crisis dispatch, electronic bed inventory, and scheduling into outpatient capacity. I think those technology solutions are going to be an increasing opportunity for us to weave all of this together and make those connections to those specialty resources, outpatient, peer supports, and other kinds of care that are going to augment and follow up with folks after that crisis episode.
Great. Thank you all for your responses. And, I just am hearing coordination over and over again. And I did want to go into a little bit more depth about something that Wendy said. A crisis counselor is really only as good as the toolkit that they have. And so I'm wondering, at the state and local level, can you share more about effective ways to increase collaboration and connections between health systems and those in crisis, and perhaps those answering the crisis calls?
I think a really important document, and some of my colleagues here are probably familiar with it, is the Care Transitions document from the National Action Alliance for Suicide Prevention. I've had the privilege to serve on that work group, and it really calls out how critical it is to have really tight care transitions when people are going from inpatient care to outpatient care, when there's such high risk. But there's also and that takes a lot of collaboration between healthcare systems, hospitals, and outpatient care. But there's also risk between, as you're handing people off in the crisis system, when a mobile crisis team is handing someone off for an outpatient visit, for example. So it's really critical that we engage in follow up, and there's never too much follow up, and that we look at the follow up from the call center perspective. And that's something I know that SAMHSA and Vibrant are working on right now, ensuring that there are follow up practices for 988 callers, follow up for people who've been seen by mobile crisis, and then follow up from people who've been seen in 23-hour units, so that we're making sure that whatever service we helped refer that person to during their crisis, that they received it, and not just that they went to their first appointment. I mean, I think we need to go beyond just that they showed up, but are they really engaged, and are they going to stay in that level of care? I think it's really critical.
Yeah, that makes a lot of sense, Wendy. I want to highlight again the launch of 988 and the increase in awareness that our country now has around mental health supports and crisis services. I want to pose a question to Dr. McKeon about, can you share a little bit more details about, the 988 rollout and some of the best practices that you mentioned that SAMHSA delivered around the delivery of crisis care? And how do you really recommend linking delivery of care to positive outcomes?
Yeah, so I will mention a couple of things. The rollout of 988 has been marked by a dramatic increase in access. David referenced some of the numbers when you're looking at calls, chats, and texts, going over 5 million in total. Over a 12-month period associated with the launch of 988 to the current day, and we anticipate that will be continuing, and we've continued to expand through different language capacities. So while we've had a Spanish language subnetwork for well over a decade, we're launched. We now have the work on the availability of video phone for those with hearing impairment. Is another example of expanding access. And it wasn't that long ago, only 4 or 5 years, when basically we were providing these local crisis centers to participate in the Lifeline network with the grand total of about $1,500 to participate. So the investment now is far more significant, and that's allowing our partners at Vibrant, who run the Lifeline, our grantee, to also be working on enhanced training. Now, call center staff, the average call center staff for the Lifeline historically probably has gotten more suicide prevention training than the average clinician, unfortunately. I often tell the story about I went to a APA-approved PhD clinical psychology program, an APA-approved internship at Yale, and the only lecture on suicide prevention that I heard, ironically, was one that I gave. It was nowhere included in the curriculum, and many people have had that experience, which doesn't mean that there aren't some very fine programs that provide great training. So the folks working the Lifeline, have been trained and are experienced, but we're working to enhance that and to help with the difficult life and death decisions that sometimes need to be made every day. And we're really working in particular, as David emphasized, in trying to reduce the frequency of police engagement in crisis services. And I think 988 is the best opportunity to do that. You know, there are going to be circumstances because of public safety issues, or maybe, you know, if we're sending an ambulance because of a suicide attempt in progress, it might be the police can get there quicker than even the ambulance squad might be able to. But yeah, 988 being connected to a mobile crisis team that can go without the police, I think is one of our best ways of reducing unnecessary, police involvement. And I think one of the things that will be particularly important in terms of best practices will be as we work to try to focus on the collaborations between different parts of the system. And as Wendy emphasized, follow up. We know no call center, no call mobile visit, ER visit, even inpatient psychiatric visit is able to eliminate entirely all suicide risk. So what's incredibly important is maintaining contact throughout an entire episode of care until we can be sure that somebody is safely connected to ongoing services. And we know that, a phone call after the mobile visit, after the ER visit, after the hotline call can be experienced as life-saving. Madeline Gould has published on this with SAMHSA support. There's a rich and robust literature that underscores the importance of having this level of connection rather than having a fragmented system where people can fall through the cracks. And interestingly, when people receive this kind of follow-up, usually we ask for consent, for that. Oftentimes they'll say, when I called, I felt awkward making the call, but when I was called, I felt cared about.
Great. Thank you, Dr. McKeon. I believe Dr. Mordecai unfortunately has to leave a bit early, so I just want to thank him for joining today. And now we're going to turn to some audience questions that have come in. The first question might be a good fit for David. What do you suggest behavioral health providers might do to overcome challenges with recruiting and retaining staff so that they can offer more access to services for people with urgent needs? And I know you do some training in this space, so would love to hear your thoughts.
Technically, the Great Resignation has ended. Not as, it's not moving as fast as we've wanted, but COVID is formally ended and the Great Resignation is formally ended. So we're taking some steps forward. But for us, the integration of peers, certified peer supports into all of these levels. So there are so many states that still take a more clinical approach to staffing, whether it's crisis receiving facilities. There are people who don't think peers should be engaged in a service like mobile crisis or crisis receiving, but the SAMHSA national guidelines are pretty clear that we ought to be utilizing people with lived experience, lived expertise at the highest levels possible. There's nothing in the call text chat of 988 that doesn't mean there should be more peers involved. Mobile crisis teams can be in partnership with a peer. And in our own facilities, we've got 25 to 35% of our staff in our crisis receiving facilities are peers. So as we're building out this dedicated behavioral health, if we steal from Peter to pay Paul and take from outpatient and urgent and specialty behavioral health, then we just make this whole challenge worse. So for us, the leaning on those, the other pieces, we're in 13 states between our software systems at Behavioral Health Link and our crisis receiving facilities at RI, and we are leveraging some of the compacts and across state supports to leverage at physician nursing and the clinical levels where that's appropriate, and we can do it. But it is the number one topic we hear talked about over the course of conferences and presentations right now.
It's very hard to keep people engaged and retained, especially given the content that they're receiving daily, weekly. I have a question here for Wendy. You mentioned that we ideally want to identify who needs help earlier instead of having their first interaction with mental health support systems being a crisis call. For you and others on the panel, how might we better identify who needs help before they're in crisis? So looking more upstream, are there any promising approaches out there?
I think it's really important to view some of the crisis lines and helplines as not just crisis lines, but access lines as well. That's why I like the name of the Georgia Crisis and Access Line. Massachusetts has just opened a helpline where people don't feel like they have to be in crisis to call, that you can call before it's a crisis. And so it's really a public health approach, really making sure that people understand what some of the warning signs are, maybe getting families to be aware of what some of the warning signs are so that they can catch things before they're a crisis. Having worked in this a really long time, usually the number one caller who calls on behalf of someone else is mom. So, can we reach out to parents? Can we educate parents on, what are some warning signs they should be looking for so that they can get, their young people access to care before it's actually a crisis?
Would anyone like to add anything else? There's still more questions coming in, so we'll just move along. One question here is about a workforce, a number of workforce questions. Can you speak to the efficacy of the CIT? I think that's crisis. Is it a crisis counselor in training programs to training law enforcement to handle individuals with mental health concerns better, and also speak to the efficacy of co-responder law enforcement and behavioral health professional team models? David, I think you might be well suited for that one.
Yeah, so look, all of us know the CIT very, very well. I actually went through the CIT training in Memphis where it launched the 40-hour training that is designed to get a law enforcement officer on the scene who has behavioral health training and is self-identified that they have a bent toward supporting that scene, and then to supporting that individual in crisis, and then that they take command, no matter what your usual command and control protocol is, that the CIT officer would be in charge. The original vision of CIT was much bolder and did include many of the aspects that we're seeing in the presentation today with 988 mobile and crisis receiving. But it was within the context of the 1980s and 90s, and we just weren't ready for all of that. So it's still a powerful component. But I think law enforcement response, whether you're talking about co-responder with ambulances or EMS or co-responder with law enforcement, that all of those specialty services will take their appropriate place to the extent that we build out a dedicated behavioral health crisis response system, that mental health crisis isn't coming in a police car, that they're coming in an unmarked vehicle and you're going to a facility with no stigma and no shame. And we're only involving law enforcement when we would involve law enforcement for any other situation. There's a threat to public safety, there's overt criminal activity, or there's an obvious medical emergency beyond the mental health, substance use, suicidal crisis. So those, I think what we've got right now is we have patched together in our communities, just like we did when we took hearses and we took coroner's vans and we took a family member and we sent John Lennon to the hospital in the back of a police car. We did what we could. So let's build out this dedicated system, and then those components are going to find their place. But I tell you, our biggest allies have been law enforcement, who don't want to drive all over the counties, who don't want to stand up against a wall in a hospital. They want to be engaged in public safety. And our hospital partners are the same way. They want to be involved in medical emergencies. And so I think that's the shift that we're going to. Let's build these core capacity in place that just simply doesn't exist in most communities. And then those other pieces are going to coordinate and work alongside.
And I very much agree, David. And I think, mobile crisis can function very well with just two caring individuals responding to someone's home in the middle of the night. And law enforcement sometimes is necessary, but the vast majority of the time it isn't. So can we build that as an option in communities and then use co-responder programs in lieu of police alone response, I think is critical.
But it is a co-responder model, Wendy, when the 988 call hub identifies that there's something concerning about that we need to secure the scene,
Yep.
or for the safety of family or the staff, that we need law enforcement on the scene. Law enforcement meets our mobile crisis team there, whether it's ours or someone else's. The mobile crisis is coming and they're partnering together. That is a co-response, even though it's not a formal one. So that occurs, but it occurs within the context, Wendy, of when it's needed, as opposed, and the same thing with an EMS response. And, you know, Richard, of course, we do have suicide attempts in progress where it is also a medical emergency. And we need medical professionals on the scene to save a life, because now it's gone beyond, because there's other medical complications in play. So it is a coordination, but it ends up being a coordination for 5%, not for the 100% of the way that we now choke everything through law enforcement and through hospitals.
No.
And I certainly agree with that as well. And I think, you know, specifically referencing CIT training, you know, because there will be times, you know, even if we are able, and I think we're moving in this direction of being able to significantly reduce the amount of police engagement, there's going to be times where police will need to be engaged, or police will be called, even if we don't think that they need to be. But, you know, that was how the call was made.
I think we may have lost that.
So when there are police there, we're certainly going to want them to be CIT trained. But that's an important part of the broader continuum of care.
Right.
Great. So I think we have time for perhaps one more question, and I did want to bring it back to 988. So it's so important to have a quick 3-digit helpline, and we know we've hit the $5 million or 5 million text, chats, and calls number for the year. How well known is the 988 number, and what else do you think needs to happen, Dr. McKeon, to bring additional awareness about the number?
Yeah, and this is something that we can use everyone's help with. Because there are still many people who are not aware of 988, you know. So our team in the 988 Behavioral Crisis Office is, you know, working to do everything we can to bring public awareness to the number 988. We were heartened. I didn't hear it myself, but I understand that President Biden referenced 988 in an announcement on enhanced mental health parity regulations that he made yesterday. In my home county of Montgomery in Maryland, the 988 is on the side of buses, and it's on Amtrak train stations. The Federal Transit Administration has been a great partner in helping to get the word out, but we need to do a lot more to get the word out. So that's one piece. The other piece that we're working on actively is doing focused evaluation work on the barriers and facilitators for contacting 988 among different groups at higher risk for suicide. We want to understand about if you are, if you're a Black teenager, or you're an older rural white male, or others who are at heightened risk, what is going to help you feel like you can make that call. And that's a critical area that where SAMHSA is currently funding evaluation work to help us understand the needs for some of these populations who are at higher risk. So we need to continue to work so that more people know about 988, that it can be accessed by phone, chat, or text, but also that for those who may have heard of 988 but are reluctant to utilize it, to understand that better and to help address any concerns that people have.
Thank you. Great. This is great. So I do want to close out our session, and we have time for one quick question. So maybe in just a few words, what is the one thing that you hope people remember after this discussion about the integration of crisis care systems and healthcare systems And, looking back on the launch of 988, what do you hope they take away in just a few brief comments? And we'll go David, Wendy, and then Dr. McKeon.
So, here's where I would start is that these systems of 988 are for everyone. Our healthcare system nationally is made around payers. Medicaid in Phoenix, Arizona covers about a quarter of the population. But the crisis call line and mobile crisis services and 23-hour are built out so that they're for all. With your primary care physician, you've got to find someone who covers your insurance. But we can't take that approach to crisis care or it yields a different approach. So I think the discussions of coordination that we've had today and connection are really where we get to the next level of this front-end system for everyone that then partners well with the providers and payers and takes us to a new level of integration like we have on the medical side.
What I'm really hopeful about is now that we're building out the continuum, that we can really look and ask people who've used those crisis systems what their experience has been like, and how we can make that experience a better one. We're doing all we can to make sure that there's collaboration and coordination, but I'm really hopeful that we bring the voices of individuals and families who are using the systems into the discussions more often, so that we know what their experience is and how we can make it better.
I'd say the importance of listening when someone's thinking about suicide, not panicking, listening in a caring way, and helping them connect to care. That's certainly part of what is done on the Lifeline, but it's also part of what any healthcare or mental health. Sometimes people need to be heard and need for someone to not overreact, but who will listen and help them get to the care they need.
Thank you so much. It's so important to have somebody to listen to and lean on, especially in times of crisis. I want to close us out by thanking our esteemed panel for sharing their different perspectives, also for your patience and flexibility. I'm so glad that we were able to have this discussion today. Today we heard about where crisis services can fit into a broader continuum of care, and we heard about the need to coordinate services and challenges in the making that coordination effective. Some themes I was just reflecting on in our conversation is that we need better coordination across all players. That is going to be critical to our success. We need data transparency that can enable better pathways and journeys to better outcomes. We need tighter handoffs at each stage of response and care that are critical. In each stage of our response and care that are critical to our success. And we really need providers to be able to easily access and have those ready resources to support people in crisis. This conversation makes me very hopeful, and we've come a long way, but we do have a long way to go, as David shared in his opening remarks. As we close out today, I want to thank the Institute for Health Policy staff, including Becky Oregon, Rebecca Flournoy, and Ben Thrutchley. We'll be posting a recording of the event on our website in the coming weeks, and you will also all receive a survey following this meeting requesting your feedback, so I hope you participate in that. Thank you so much for joining us today, and we look forward to seeing you on a future IHP forum.